Okay, last but not least, let's go ahead and dive into leukemia. Leukemia is the most common cancer in children under 14 years of age, and although we do see adults with it as well, we do think of it more as a pediatric cancer. Basically, it's characterized by too many white blood cells. The bone marrow is affected and is just churning out way too many white blood cells. The white blood cells have not had a chance to fully mature, so they don't work right, and then they're crowding out all of the other cells that are supposed to be developed in the bone marrow. So we'll have tons of white blood cells, not enough red blood cells, and not enough platelets. There are different types. ALL, acute lymphoblastic leukemia, has a little star next to it because that's the one we're going to spend most of our time on today. We'll also look at acute myeloid leukemia. The two chronic leukemias there, chronic lymphoblastic and chronic myeloid, are more adult cancers. They're not cured, they're just managed, and so we really aren't going to spend any time on them today. There are other rare forms. There's one called hairy cell leukemia. I just like the name. But again, if you're interested in that, go ahead, take the time, look them up yourself. But we're going to be focusing on the two acute leukemias today. These slides here, I just want to demonstrate for you the change in types of cancers depending on how old your patient is. So you can see that under 5 years old, leukemia is actually the most common cancer we see. Even from 5 to 9, we're still most common, although brain and CNS cancers are catching up. By the time we get to 10 to 14 years, they're all fairly equal. And then 15 years and older, we start to see things like carcinomas and lymphomas taking over, and leukemia becoming less prevalent. There are some other risk factors we know are associated with developing leukemia. If you remember way back to Down syndrome, there's a higher risk of leukemia with Down syndrome. An immunodeficiency puts you at a higher risk for any kind of cancer. And we also know that exposures to certain chemicals and radiation increases your rate of leukemia. For example, in Japan, after the nuclear bombs were dropped, the rates of leukemia in the country skyrocketed. Unfortunately, it looks like they may again be experiencing higher rates of leukemia related to the meltdown that happened after their huge earthquake and tsunami. So again, there's just rapid production of these immature, ineffective white blood cells, and so there's limited space for the erythroblasts making the red blood cells and the megakaryocytes making the platelets. The symptoms we'll see can be very nonspecific, meaning it doesn't necessarily point to leukemia, just points to being sick. So for example, having a fever, it could be anything, right? A virus, a bacterial infection, or it could be leukemia. The pallor is related to lack of red blood cells. The abnormal bleeding is related to those decreased platelets. The lethargy, again, back to being anemia. Loss of appetite, anorexia. The joint and bone pain is actually related to the pathophysiology going on right inside the bone marrow. It's, rather than bone pain, it's almost like it's bone marrow pain. The big liver and spleen and the big lymph nodes are all related to the white blood cells that sort of collect and start to clog up these various blood filtration systems. If you want to see more of a personal story of some of the symptoms associated with leukemia, go ahead and watch the video there on the screen. To diagnose leukemia, we first start by looking at the blood counts. Just with a venipuncture, draw some labs, see what we see. So, of course, we expect to see high white blood cells, low platelets, and low red blood cells, or hemoglobin. But to truly diagnose this as, yes, this is caused by leukemia, and to determine what kind of leukemia, we do a bone marrow aspiration. Actually collect some of those blast cells from the bone marrow, and you can see them under a microscope and determine which cells have the problem, what type of leukemia is it. If there's any concern that the cancer may have spread to the central nervous system, the patient will also have a lumbar puncture to see if the diseased white blood cells have made it into the CSF. For treatment, we're going to look first at ALL, acute lymphoblastic leukemia. There will be radiation if there's CNS disease, or if it's the T cells, or if there's any testicular involvement. Otherwise, it's mostly chemotherapy that we rely on to treat ALL. The treatment for ALL is very well researched. A lot of patients have undergone the procedures. We can even just sort of hand a family a calendar of here are the days when your treatments will take place and here's what they will be. So these are the different stages. We start with induction, a nice whopping dose of chemotherapy to try to kill off as many cancer cells as possible. But we know we haven't killed them all off. So then the next stage is called consolidation. We sort of step up the treatment and kill off those resistant cells. And then the final step is delayed intensification. That's one more step up just to make sure we have killed off every cancer cell. So at the beginning of each of these 3 stages, this is when the patients will experience the most side effects from their chemotherapy. Finally, when they're done with all those stages of chemotherapy, there's a maintenance regimen to keep the cancer away. That can last, the first 3 stages last a few months, the final stage lasts a few years. For acute myeloid leukemia, AML, we really don't have the same reliability of treatment. It's very intense. It requires both chemotherapy and radiation, and we go straight to a bone marrow transplant for this one. It is very intense. The patients require a lot of physical support to even just survive the treatment. So let's take a minute to talk about chemotherapy. What is it, and why is it so toxic? If you think about antibiotics, generally we know they have some side effects, but it's not the same devastating effects on the body. The difference is that with antibiotics, we're fighting bacteria. They're foreign cells in your body. They don't even have a nucleus. They're fairly easy to kill. With cancer cells, they are your body's own cells that have just gone haywire. So if we're going to be able to kill off cancer cells, really we'll be affecting every cell in your body. The difference is that cancer cells are weak and they don't recover as easily. So although all the healthy cells in your body should recover, the cancer cells will then die off. The body's immune system also helps out with any cancer cells that are left, as long as we haven't wiped out the immune system with our chemotherapy regimen. The damage to the healthy cells is what creates the side effects for the patient experiencing the chemotherapy. So for example, if someone's hair falls out, it's because the hair follicles have been damaged by chemotherapy. If someone has extreme nausea and vomiting, it's because the GI tract has been irritated by the chemotherapy. And as I mentioned, the ALL is based on really well-documented protocols. Other forms of cancer don't have that same luxury. While someone is undergoing chemotherapy, the actual duration and intensity of that treatment is limited by the side effects. If someone has hair loss, that doesn't make us stop the treatment. But if someone is experiencing bone marrow suppression, they essentially are not making any blood. So we can't continue until that bone marrow has regained its function. Neurological toxicity has the potential to cause permanent defects, renal and liver damage, again, permanent defects. So sometimes we actually have to stop or delay treatment to allow the healthy tissues in the body to recover before we can continue with the chemotherapy regimen. It always requires close monitoring. Vital signs helps us keep an eye on heart and lung function, of course, as well as giving us some insight into electrolyte balances. Body weight, INO for fluid balance. We actually use blood tests to monitor liver and renal function. And then, of course, blood cell counts to keep an eye on bone marrow function. Chemotherapy can also cause some emergencies. The first here is called tumor lysis syndrome. This makes more sense with some other forms of cancer. So if you envision someone has a large tumor, the chemotherapy is effective and starts rapidly breaking down that tumor, then there will be all these toxic waste chemicals released into the blood. With leukemia, the same phenomenon can occur. It's just that the tumor is in essence spread out across the whole body. Each little leukemia cell is like a little tiny tumor. But again, if they all burst, they're releasing all of their toxins into the bloodstream, and that's a life-threatening emergency. The chemotherapy can also decrease someone's immune function to the point where they can become septic or get meningitis or some severe pneumonia, and of course that puts the child at risk for death just from the treatment rather than the cancer itself. Chemo also destroys bones and can release excessive calcium into the blood. And if you go back to your fluid and electrolytes content, you can go ahead and look at all of the symptoms that come with that. From a blood standpoint, from that bone marrow standpoint, we might see severe anemia, so lack of red blood cells. We might see severe thrombocytopenia, or lack of platelets. We can also see something called DIC, disseminated intravascular coagulation. And you'll learn more about this in OB, but essentially the blood is clotting where it should not be, and it's not clotting where it should be. So you have blood clots floating all around your body, getting stuck in your lungs and your heart and your brain, and then you're bleeding out from your eyes and your mouth and your rectum and other places you're not supposed to be bleeding. The last one there, leukocytosis, is not actually a chemotherapy-related emergency, but it is related to leukemia. If that white blood cell count gets too high, the white blood cells just make the blood too thick to flow appropriately, and so then we start to see sort of sickle cell disease-like symptoms from the huge number of white blood cells in the bloodstream. I think I mentioned really early in class, before we got our snow day, that we would be talking about bone marrow transplants here with leukemia. So let's go ahead and look at it. Of course, the layman's term is bone marrow transplant, but you might also hear it called a hematopoietic stem cell transplantation. Those hematopoietic stem cells are blood stem cells. So we're taking them out of someone's bone marrow and putting them into the cancer patient's bone marrow. If a patient somehow can foresee that they will need a bone marrow transplant, it is possible to donate to yourself. But of course, if someone with leukemia tries to donate to themselves, they're just giving themselves cancer again, so that won't work. The next best step is isogenic donation. This is if an identical twin can donate to you. Of course, most of us don't have that luxury. So what we rely on is allogenic donations. This is just like any organ donor. We have to make sure all of the right antigens match up. If you find a match, you're good to go. For ALL, we only do bone marrow transplant if the patient has relapsed. They've gone into remission and then they relapse. For AML, it's actually used as a first-line treatment. We do it as soon as the patient is diagnosed. So what's entailed? Let's have a look. The bone marrow donor has a large needle inserted into the bone marrow somewhere in their body, normally in the hip or leg bone, and those bone marrow cells are collected. They then go to the lab where they're processed and actually remultiplied. And then we come to the patient. They have high-dose chemo or high-dose radiation to kill off all of their bone marrow. I think you can imagine that this is very toxic treatment for the patient. And then, of course, they are essentially without an immune system. So they're in very tight isolation. We then take the cells and reinfuse them. The cells are smart enough to know they belong in the bone marrow space, so it's actually just an IV infusion that the patient receives, and then the cells migrate to where they belong, those spaces in the long bones. We don't have to take the bone marrow cells and put them straight into the bone marrow. Just into the bloodstream is good enough. So the phases here, we have pre-transplant, that's that high-dose radiation or chemo to wipe out the bone marrow. Then the patient receives the transplant, and then for several weeks post-transplant, they're still recovering. It takes a few weeks for that new bone marrow to actually kick in. They have to also take immunosuppressive agents to make sure that they don't reject that new donation. That's called graft versus host. So that patient is in strict isolation, and for about 10 of those days, they basically have no immunity. Of course, this is not an easy process to go through. So from a nursing standpoint, we're anticipating high anxiety for our patients. Again, like any chronic illness, they're experiencing that loss of control, and also an anticipated, or a feared anyway, loss of future. The parents are wondering if their child might die. Like any chronic illness as well, we're going to see developmental issues, disrupted family processes. For the child who's going through the treatment, they might have disturbed body image. If they lose their hair or gain a lot of weight or lose a lot of weight because of the chemotherapy. And then, of course, with these issues about immunity, the patient will also experience some social isolation. So here's what we can do to help out. Promoting nutrition, making sure they're taking their medications as they're supposed to. With chemo and radiation, you need to remember to protect yourself as well. For chemotherapy, there are special gloves and gowns and masks that you wear to make sure that you don't accidentally administer any of these toxic agents to yourself. For radiation therapy, nurses who work routinely with radiation actually wear little monitors. Even X-ray technicians and CAT scan technicians wear these little monitors just to make sure they're not overexposing themselves to radiation. Of course, we want to teach about hand hygiene and other ways to prevent infection. If the patient is experiencing pain, we as nurses would then manage that. And of course, promoting rest not only for the patient but for the parents. One of the things I love at Hershey Hospital is the Ronald McDonald House is there. It allows the parents to actually go sleep in a real bed instead of staying in the hospital if they'd like to take that option. They can do laundry there, cook their own meals instead of having to go eat at the hospital cafeteria all the time. And they even bring breakfast in for all of the parents staying at the hospital overnight. There are some cases where the family needs to know to call the doctor. So here you go. Fever, again, it could be a sign of a serious infection. Any bleeding, we are thinking about low platelets. Any kind of pain with elimination, sores in the mouth, vomiting, diarrhea, these are all related to chemotherapy side effects. And then cough, runny nose, tugging at ears, again, maybe they have a serious infection that needs to be addressed. Of course, if they have a central line, we'll do all our normal central line teaching about observing for signs and symptoms of infection. And then anytime a patient undergoing chemotherapy or with leukemia is exposed to a known communicable disease, then they need to alert the doctor. So for example, this measles epidemic that's going around. If a patient is undergoing chemotherapy, it basically wipes out all of their immune system. So even if they were previously vaccinated with the MMR, they are now newly susceptible to the measles and need to be preventatively treated against that. So what happens to these patients with leukemia? Well, we do know some low risk and some high risk factors. So a patient who's between 2 and 10, they're in a good age range. Normally they do well. Strangely, if they have low blood levels at diagnosis, they tend to do better. With much higher white blood cell levels or a really young age, we know that they have a harder course of treatment and don't necessarily have the same great outcome. About 10% of kids with leukemia will relapse within a year. That's when we will go to a bone marrow transplant for them. But the issue here is that chemotherapy and radiation can cause other cancers later in life. So if someone is treated for leukemia when they're 2 years old, they may then end up with bone cancer or breast cancer or kidney cancer as a result of the treatment that cured their cancer as a child. We also know that chemotherapy itself can cause things like osteoporosis, kidney stones, so not even necessarily cancer, just other chronic conditions. So for leukemia overall, the long-term survival rate is 70%. For acute lymphoblastic leukemia, ALL, we're actually at 80%, but then you can see that for AML, that more difficult leukemia to treat, we're down as low as 45 or 50%. Okay, so that does it for leukemia and for our hematology lecture. I hope you all stayed safe in the snow and drive carefully in the morning.